Hi there, thanks. It's really great to be here to share this work because it's really your work. And I really want to pause for a minute to say thank you, not only to all of you who are good users of the tools, but also to all of the analysts and things that make my work possible. So anyway, we're going to be on a bit of a journey today. That was very quick. There are the objectives. The biggest thing I want to make sure of is that by the end that you understand a little bit more about the NEAT tool. The NEAT tool is the Nursing Efficiency Tool. We're going to talk about what that is and how it works. And we are some of the first. We are leading the way in this work across the EPIC users in the country. So remember that there is a business case for the single instance of EPIC, and we're all about getting there. We're almost all there. Our Wisconsin colleagues are a little bit nervous because Saturday is the day. The last large merge will happen at Saturday morning at 0200. But the biggest part of this is having that single platform that we can all have the common conversation about what is it that drives our work, because the workflow engine is the EHR, is EPIC. And so there were a lot of things that made this possible, but it was really the dedication of our administration to understand that we really needed that single resource, that single base, and understand that. So it became part of the strategic plan to get to one common platform of the EHR. We were doing so well. All right. So what we started out to do, and many of you were there, some of you were there, some of you were all a part of the work that we've been doing or that you've used it since it's happened, and that was we started 2 years ago to build what we called Simple Elegance. We wanted a simpler build. We wanted to make sure that we looked at the usage, that we removed the things that were in people's way, and if it was an awkward process, we reviewed that and made it better. We removed a lot of the scrolling. We had several fields that people had requested. We had 46 items in one of those fields that people did not use. So we had, out of those 46, 8 of those were used. So we took out the other 38. And so in order to make it simpler and easier for you to use, we reduced a lot of those large category lists, and we reduced the duplication. So we had several workshops. Some of you might have been there, but we focused at those workshops about the whole package. We looked not only at the nursing work, we looked at the physician work, we looked at the pharmacists, we brought in the therapists, and we did that multidisciplinary work across all of those. We included the SLU care physicians as well, so that they would be able to go on to the system, which they did in April. And we built consensus and supported for that single standardization, and where we needed to, we considered regional variation. This is kind of an important slide, so I'm going to go back to this one, maybe. All right. I think it's really very important for everybody to understand that we used our value of respect, because every one of these instances of EPIC meant something to someone, meant something to you. SSM Health was the first 3 states. It was Illinois, Oklahoma, and Missouri. All of that build meant something to you. It all meant something to the folks in Wisconsin about the way that the record was built and supported their work. And then as well at St. Louis University Hospital, that work meant something to them. So we had to look at that and understand that and utilize our value of respect to say, what is it that we need to pull together to meet in the middle that's going to allow us to provide better care and be simply elegant. And where we couldn't come up with something that was better, that improved our care, we used the foundation system of EPIC, our vendor. And the reason we did that was we know that that's the direction they're going in, and we wanted to be sure that if that was the direction that they were going in, that we were going in the same direction. So we had several of those sessions where we met together. We looked at the top 10 workflows. These were the top 10 workflows that our users told us that we needed to make sure that we looked at and understood. So these were the workflows that we worked at. We had 2 large workshops. One was here in St. Louis, one was in Wisconsin. And we worked through all of those different processes that we were asked to look at and make those processes more streamlined. All right, so the results. We added clicks, we took away clicks, we removed things, we added things, we kept track of every one of those clicks. Very begrudging, our analysts did a wonderful job of understanding what that is. So then by the time we got done, what did we understand? We understood that we had saved 140 million clicks from July to December. When we applied our patient days, we would have saved 140 million clicks. And we could have stopped there, because it was breathtaking. But we decided that that was not really going to tell the story, and what I started to work with as far as our nursing informaticists across the system was to understand this work in a different way. All right, so this was a hallmark study that was done in 2008, long before we really knew where we were headed with all this electronic journey. And many of you may see that this is Marilyn Chow, who is the CNO at Kaiser Permanente, as well as Ann Hendricks, who is the CNO at Ascension. They did some really great work. They worked with 36 hospitals. They gave those nurses PDAs. And as the nurses did the work, they were to document how many minutes it took, where they were, what happened during that period of time. What we started to understand about that work, though, that was the first big study that was done to really understand what it was taking to do nursing documentation in the paper world, getting ready for what the ANA said in their position statement, a much better system, the electronic health record. Now, you can debate all of this, because if you turn to your colleague right now, they would say, oh, I spend whatever % of time documenting in the record. All right, and here is one of the documented places that they've identified at Cornell, and colleagues found that some of the nurses reported spending as much as 60% of their time documenting in the record, which is untenable. We can't have that kind of time. But here we are in the Carolinas. They've done something very similar. They saved 18 million clicks, but we don't know the time. So the thing that was really important to understand about this was to start to understand and put timers into the workflow, to understand when the nurse logged in, not only how many seconds it was taking you to call up the system, but putting timers into your work to understand from the time you started to the time that there was 30 seconds, there was no more activity. Where you'd been in the record, what you've done in the record, and how it all worked together. That's the nursing efficiency tool. We put the timers in the record so that we could understand what that was. So we took the first cut of data, and the first cut of data was done in January of 17, before we made all the changes in July of 17. We understood what that data understood, and then in December of 17, after those changes were made, we took another cut of data, and what we understood then, there was a reduction of 17 minutes per nurse per shift in what we had done. So we could have stopped there and said, we met simple elegance. This is one of the highest numbers that Epic has seen in the data, because they've started now to produce this data for other hospital systems. But what we really wanted to understand is how we can use the data for the good. So this is the neat timing, the first run of data, just like I described, and then where we did the implementation in July of 17, and that next run of data. This is the big picture of understanding what our units look like. These are the number of minutes of over 250 observations on each of those units to understand what and how much time is being spent in the record. Now remember, if you're a 12-hour nurse, that's 720 minutes. And so we need to understand what those minutes start to look like when we are looking at the utilization of time. So each of these observations, and the interesting part is, if I was savvy here, hold on, I brought a pointer that I understood. What we understand is that all of There are no EDs in this data. But the thing that we need to continue to understand then is what does it start to look like when you start to look at med-surg units. So looking at this, we can see that there's two units here. Their case mix indexes are the same. They're as much and as close as you can possibly get. And what we see here is that one unit used 193 minutes average documentation of their nurses per shift. And you can see also then that the minutes per hour, that you can see along the top how they're spending their time. Now, I know this is a little bit hard to understand, and that's why I want to spend a little bit more time on this. So what we can understand about this slide is that this is a comparison of nurses on the day shift on these two units to understand that one unit, which was a medical unit, just like the other medical unit, one unit spent 222 minutes and one unit spent 193 minutes on average doing their documentation. So working through that to understand a little bit more, it becomes more important to understand, especially as nursing informaticists. I'm gonna stop the slide business. You can take it over, Ann. Let's understand what's happening in those minutes that makes that a little bit different. And what we start to understand is that it isn't so much in this case the orders, but pay attention to the box because those are the number of orders placed by the nurse per shift. And then notes, understanding that on one unit, the 3.3 notes per shift were being done by the nurses. And on the other unit, that's where their time is being spent. That difference in the time, there were 6.9 notes more filed. So more notes being filed, 105% of that time, that is the difference, is being spent in notes. So understanding, because remember, this is data. What we now need to understand is how are those notes being done? What are those notes telling us? Are they necessary? Are there notes that we're filing that we don't need to do, that we are now providing duplication? So it's one more point of data to understand. The administrations, this is medication administration. And you know, some units are going to have more meds than the others. Some of them are going to be more difficult than the others. So this is just understanding those two units in comparison, and for the first time we can now understand it isn't 60%, it isn't 50%, it isn't 40%. Now it's closer to 30 and 28% and 25% of the time that you're actually spending doing the documentation. Next slide. This was also a very interesting thing, and it's a very important thing for nursing informatics to make sure that we're supporting you, our customer, the right way. And this slide indicates that we have the large buckets of work all in one area. Because if it wasn't, and we didn't do this in such a way that we provided flow sheet rows and documentation for you in one large bucket, then we'd have you bouncing all over the place. So it's more to understand that we've got the documentation in the locations that we can keep the nurse in that location of their documentation as an efficiency tool for you. All right, so this was really great learning for the nursing informatics people to make sure that we provided the right tools at the right time. And that's what this screen says. Next slide. All right, so the nursing efficiency tool, I think it's really important that we understand the data, that we understand what it is, what's it telling us, so we can make the tools better for you, the tools that you're using every day. And we need to understand the data for the good. This isn't to punish anyone. This is data to understand. We've been talked about as far as the documentation burden for so long. Let's really understand what that is so that we can make it better. And then continue to have nursing informatics really understand those variances to support you, the SSM nurse. Next slide. I think it's really important that we always honor and remember where we've come from. The 5 sisters, they started out with $5. Times were very challenging. What we're offering and trying to offer with the right tools at the right time is to give you that time to being able to have presence and be able to have more time at the bedside with your patient so you can do the things that we learned about this morning. Center yourself to make sure that you're there to hear that story. Next slide. Oh, there was a really nice quote, and that's where we'll end today, and that is, they were filled with courage and confidence. And I am filled with courage and confidence that we can continue to make this better to work for you, that it doesn't have to be the awful burden that a lot of people are describing, and that we can make those tools more important for the care that you're being able to give. So thanks for letting me share today. I really appreciate that. I don't appreciate this little tool, but I do appreciate your listening and your participation. Thank you.